Our objectives in this session are to talk about how to diagnose bone tumors, strangely enough. We're going to look at certain discriminators or findings that we should systematically look at in every case to help us narrow our differential diagnosis. This is meant to be a practical talk, how to approach bone tumors. We'll talk briefly about staging, and then we'll talk about how to classify bone tumors into one of 6 big categories. Because if you can do this and then say if it's benign or malignant, life or an examiner will not be failing you. Finally, we'll have a lightning round with Aunt Minnie to review the highlights. Okay, first, the discriminators. In every case, we should have a systematic approach. I like looking at the patient age. If you're not given the actual chronologic age as an unknown case, you can, of course, look and see if they're open physes or secondary OA or something like that to give you a clue as to the correct age. Lesion location, also very important. Pattern of bone destruction, as radiologists, we're trained to look at. Tumor matrix, we'll talk about in detail, and then tumor extent, of course. So this is my systematic approach. First, patient age. Timing is everything. There's nothing statistically more important than patient age. And we're going to just do a quick overview of bone tumors by patient age just to give you a quick feel for what some of these look like. In young patients, ages 1 to 15, here a 7-year-old male with a lesion in the temporal bone due to LCH. So you have to think about Langerhans cell histiocytosis in this age group. Now, it turns out that bone is going through a lot of development in the 5 to 30-year-old age group. So there are a lot of tumors to consider. They're both malignant tumors, like osteosarcoma, as well as other malignant lesions like Ewing sarcoma. We'll talk about all of these in a lot more detail. We're just giving a quick overview of lesions by age. Many benign lesions also occur in this age group, non-ossifying fibroma, shown here. In addition, solitary bone cyst, shown here. Another one, commonly diagnosed in the 5 to 30-year-old age group, aneurysmal bone cyst. Another one, fibrous dysplasia. And then, less commonly, but still one that is, I think, very good to know about if you see many bone cases, chondroblastoma. We'll talk more about those in excruciating detail, believe me. In the 20 to 50-year-old age group, giant cell tumor of bone is a prime consideration. Over the age of 30, there are some sarcomas like chondrosarcoma and fibrosarcoma that we consider. Over the age of 40, I'm sad to say, it's all downhill. Mets and myeloma are prime considerations. I can't say that metastases is a favorite in Louisville in the bone section. It's just not considered a very intellectually stimulating topic for many people because it's so common in clinical practice. But again, I'm just speaking as a private citizen, not as an examiner. Lesion location. Location, location, location. Key. So, for example, if we see an aggressive lesion in the diaphysis of a long bone in a young patient, Ewing sarcoma is a prime consideration. The list gets pretty long, however, in the metaphysis. Non-ossifying fibroma, osteochondromas, various sarcomas all occur in the metaphysis. This is an active area of bone, particularly in young patients. The epiphysis is an area where the differential diagnosis gets shorter again. Of course, in older patients with OA, we see subchondral cysts all the time. Here on a fluid-sensitive image, it looks like fluid, right? Here, another epiphyseal lesion, but this one in a skeletally immature patient. It's low in signal on a fluid-sensitive image, surrounded by a lot of edema. These findings are characteristic of a chondroblastoma. In the epiphysis and the adjacent metaphysis, giant cell tumor of bone, and we'll talk more about all these shortly. But I want to give you an excuse to see lots of different examples. So look at patient age, look at lesion location, and then try and describe the pattern of bone destruction, because this reflects the biologic activity or growth rate of a lesion. So, lesions are characterized as looking aggressive if they have a permeative or moth-eaten pattern of bone destruction, in which the zone of transition is wide and the lesion margin is typically not sclerotic. Now, you'd be hard-pressed to give a specific diagnosis, histologic diagnosis in this case, but you can say it's an aggressive lesion, and in fact, it was lymphoma. What about non-aggressive lesions? They're typically described as geographic with a well-defined border, a zone of transition that is narrow, and a lesion margin that is often sclerotic, as in the case of this solitary bone cyst. So, patient age, lesion location, pattern of bone destruction, tumor matrix. Why? Because this can help us classify a lesion by tissue type. So, for example, if we see a matrix that looks osteoid, commonly described as ivory or fluffy or cloud-like, like we see here, we'll think about osteosarcoma, which was present in this case. On the other hand, chondroid calcification, commonly described as calcification that looks like arcs, rings, punctate, or stippled calcification. Of course, we're going to think about chondrosarc, as was present in this case. What about this matrix? I should have gotten those Lippincott people to chip in for a right answer here. Well, this matrix has been described as ground glass. Whether or not you like that term, it's commonly used to describe this hazy opacification associated with a patient who has one of these fibrous dysplasia lesions. So we have these discriminators. We look at the patient age. We look at the lesion location. We look at the pattern of bone destruction. We look at the tumor matrix, if there is one. And then we look at the tumor extent. And one way of looking at this is whether the lesion is in one bone or in multiple bones. If you're fortunate enough to have a case in which you have a lesion that is polyostotic, the differential diagnosis becomes quite finite. The differential diagnosis for multiple lytic lesions in bone, sometimes people remember by the mnemonic FEMI. FEMI includes fibrous dysplasia that was present here in the polyostotic form, EG and enchondromas that may be multiple, as well as Mets and myeloma, hyperparathyroidism causing multiple brown tumors, and, as was mentioned earlier, we must never forget about infection as a potential mimic for actual neoplastic lesions in bone. Keep that in the back of your mind. Well, after we've gone through in a systematic fashion and analyzed the case with those discriminators in a logical way, whether we're in Louisville or in our hometown, ideally we need to commit to what we think is going on. One report conclusion might be that we're dealing with a presumably benign lesion, a don't-touch lesion such as this non-ossifying fibroma, and we'll talk more about non-ossifying fibromas later. Another report conclusion might be that we're dealing with an almost certainly benign lesion. Follow-up x-rays are considered prudent and reasonable. Examples of this include fibrous dysplasia, and in this case, heterotopic ossification. Many musculoskeletal radiologists also suggest a third category can be used, benign symptomatic lesions. Surgery, such as curettage and packing, as what's done in this case, may be performed for some of these lesions, like a giant cell tumor of bone, chondroblastoma, or in this case, a solitary bone cyst. Yet another report conclusion is that it's equivocal. We, based on the findings, don't know whether it's benign or malignant. We try to keep this group small because in many cases these patients need to go on to biopsy, and in this case, biopsy was done and myeloma was the diagnosis. Finally, the last type of report conclusion that many musculoskeletal radiologists advocate is that we're dealing with a presumably malignant lesion, such as this osteosarcoma, in which we see an aggressive sunburst pattern of periosteal reaction. What about staging? Well, there are three variables that go into staging, particularly malignant musculoskeletal tumors, like the bone tumors that we've been seeing. One component, one variable is the histologic grade. Under a microscope, they look either low grade or high grade. In addition to the histologic grade, one looks at the local tumor extent. Often with imaging, we can determine whether the lesion is contained within the compartment of origin, intracompartmental, or whether it has traveled outside of that compartment and is extracompartmental. Besides histologic grade and local tumor extent, of course, with imaging, we're commonly helping to stage patients by looking for metastases that define stage 3 disease. So even if you forget these three variables, however, keep the following concepts in mind to make any potential examiner and at your program, not in Louisville, heaven forbid I mention Louisville, happy. Number one, big picture, stratify patients into groups for prognosis and treatment. That's one reason that staging is done. It should properly be done as a multidisciplinary effort. And another thing that people who are knowledgeable about this field like hearing is that ideally biopsies of primary musculoskeletal neoplasms should be performed at the institution doing the definitive treatment. With metastatic disease, it may be a different kettle of fish. Okay, let's go on and talk about classification of bone tumors according to what the tumors look like under a microscope, whether they look like bone or cartilage or fibrous tissue, whether they look like vascular, marrow, or various other miscellaneous tissues. Because that's what the histologist is going to be talking about, pathologist is going to be talking about, and that's what we want to try and predict as well. The first category that we're going to be talking about is the osteoblastic lesions, both the benign ones, such as an anostosis, osteoid osteoma, and osteoblastoma, and of course, malignant osteosarcoma. First, the anostosis, commonly referred to as a bone island. These are sclerotic lesions in cancellous bone. They may have some spiculated margins, but that should not dissuade you from the diagnosis of this benign incidental lesion, even when they're giant. Some people call them giant when they're greater than 2 cm in size. Of course, we see these all the time, not just on radiographs, but also on CT. The differential diagnosis may, in some cases, include a blastic metastasis from a primary prostate, breast, or GU tumor. Appropriate workup that you might recommend in some cases is a bone scan, which will be negative. With bone islands, we see them all the time on MR as well as these signal voids within the marrow space. What would your diagnosis be in this case? Osteopoikilosis. Osteopoikilosis is simply a condition of multiple bone islands. It's clinically insignificant, except that we need to differentiate it from blastic metastases. What about the diagnosis here? A cone-down AP view of the femoral neck, where there is some faint lucency surrounding a small mineralized area in the femoral neck. There is the CT scan showing more definitively the presence of a nidus in an osteoid osteoma. Now, the nidus with an osteoid osteoma measures less than a centimeter and a half in size by definition, whether or not it has central calcification. Often, these lesions are surrounded by dense reactive bone. Here's another example, hard to see on the radiograph, but on the CT scan, it's more precisely seen. Sometimes these can be multiple as well. You know the mantra, aching pain, worse at night, relieved by aspirin. Again, here, a small lucency, this one in the cortex with surrounding hyperostosis. So what is the appropriate imaging workup if we see an area of sclerosis in bone, like in the ilium here? MR, CT, bone scan, what do we recommend? I would argue that the ideal next step is a CT scan because it so nicely and definitively shows a small nidus with the surrounding sclerosis. It turns out that MRI can show the nidus if there's sufficient spatial resolution, but often people are so impressed by the intense surrounding edema that they'll walk by the nidus. So if you see a lot of edema, look for the nidus, but CT is probably the easiest way to make the diagnosis. One more example, since osteoid osteomas are common and a perennial favorite of musculoskeletal radiologists, radiograph, axial T1 MR. And here, the bone scan, sizzling hot, tracer accumulation, another osteoid osteoma. In the differential diagnosis, the short list, of course, Brody's abscess, that can look very similar, and you've heard all about infections already. What about osteoblastomas? Well, here, by definition, the nidus is greater than 1.5 centimeters. The histology is similar or the same as osteoid osteoma. With osteoblastomas, the target site is typically the posterior elements of the spine and flat bones such as the rib, as we see in this case of an osteoblastoma, with an osteoblastic matrix. Osteoblastomas are commonly expansile. They may be lytic and or sclerotic. Here's one in which we see an osteoblastic matrix, a sclerotic matrix, involving the pubis. Here, frankly, although I know it's an osteoblastoma, it's a rather nonspecific appearance. There's some expansion, but it's a lytic lesion without much matrix, and it would be hard to make this diagnosis on the fly. This case, on the other hand, is rather classic for osteoblastoma, affecting the spine posterior elements, a accompanied by some scoliosis and increased tracer accumulation. This is a characteristic appearance of osteoblastoma. And so when you see a lytic lesion in the posterior elements, some people like to think about the mnemonic go ape, where the G in go ape is for a giant cell tumor, and O is for that osteoblastoma that we've been talking about. Other entities that can cause lytic lesions in the posterior elements of the spine include ABC, pictured here, plasmacytoma, and EG, eosinophilic granuloma. Note the fluid levels in this ABC. Now let's talk about malignant osteosarcoma, the second most common primary malignant bone tumor. As you probably know, osteosarcomas are most commonly of the conventional subtype, affecting the metaphyses with this sort of permeative area of appearance of bone destruction that's ill-defined. We look for aggressive periostitis and a bulky soft tissue mass, conventional osteosarcoma. Of course, on CT, we can see this rather disorganized osteoid matrix with underlying bone destruction, indicative of an aggressive osteoid neoplasm. On the corresponding MR, we can see the bulky soft tissue mass, as well as the reactive zone of edema that needs to be addressed with any definitive treatment of osteosarcoma. One more example, characteristic location for an osteosarcoma in a young patient, heterogeneous contrast enhancement also is demonstrated. Where do we look for Mets with osteosarcoma? Most commonly, they go to the lungs and to the bone. And when looking at the bone, we need to especially look in the same bone, more proximally, for the so-called skip lesions that can occur in about 10% of individuals. Now, there are some other types of osteosarcomas that I'm sure you've heard about. Telangiectatic osteosarcomas are particularly aggressive sarcomas that present as lytic lesions that only have minimal osteoid that may not be visible on our imaging studies. What we do see are aggressive lytic lesions that have intralesional hemorrhage with associated fluid levels. That's our clue that we might be dealing with a telangiectatic osteosarcoma, since osteoid may not be seen. There are some less common types of osteosarcoma. Parosteal osteosarcomas are relatively low grade with a relatively good prognosis if caught early enough. You can see that they have an exophytic appearance. Unlike an osteochondroma, there's no medullary bone entering into this osseous excrescence. They're diffusely, densely mineralized. Here another example of an exophytic, densely mineralized parosteal osteosarcoma. Interestingly, the periosteal osteosarcoma, also extrinsic, doesn't produce a bunch of bone, but classically appears as a saucer-like area of cortical erosion. Periosteal osteosarcoma. And finally, the secondary form of osteosarcoma, typically occurring in older adults with certain predisposing risk factors, namely Paget's and a history or a history of radiation therapy. I'll show you in this patient who had radiation for her breast cancer that the field included her scapula. She had osteosarcoma that we can see on this CT scan, this disorganized osteoid matrix. Secondary osteosarcoma. Let's move on to the chondroid tumors, both the benign ones, like enchondroma, chondroblastoma, and osteochondroma, as well as the malignant chondrosarcoma. First, enchondromas. You know them, you love them, geographic lesions with a narrow zone of transition, and we almost invariably see a chondroid matrix on radiographs and CT. That is, unless we're looking in the hand, in which case a chondroid matrix may not be present. They're pretty common in the hand, in fact. Complications that we need to look for with enchondromas include fractures that can occur through any lytic lesion, of course, and dedifferentiation into chondrosarcoma that we'll talk about a little bit later. Here's an unknown case to challenge you and really wake you up, I'm sure. It presents in kids as an asymmetric limb deformity. And we're talking now about multiple enchondromas that are found both in Ollier and in Maffucci's syndrome. Now, this used to confuse me because I thought, gosh, these don't look like the enchondromas, those solitary enchondromas we were just talking about. Rather, with these conditions, what we see are chondroid lytic lesions that have this sort of bizarre deforming columnar configuration. And these lesions are at an increased risk for sarcomatous transformation. So with Olliers disease, here we see that sort of bizarre columnar, streaky, deforming appearance of these multiple enchondromas in classic cases. Maffucci syndrome also has multiple enchondromas, but we also see soft tissue hemangiomas, and in this case, multiple phlebolysis. With Maffucci syndrome, there's a particularly high rate of sarcomatous transformation, up to about 20% as occurred in this patient. What about chondroblastomas? We alluded to them a little bit earlier. They're seen as a geographic lytic lesion. Here, this isn't a subchondral cyst. It's subtle, but you can see that there's no OA in this joint. This is a young patient with an epiphyseal lesion. Chondroblastoma, a characteristic diagnosis. On CT, we might see chondroid matrix as well as a thin surrounding margin of sclerosis. Again, a characteristic location, the epiphysis of a young patient, chondroblastoma. Osteochondromas are actually quite common, typically affecting the metaphysis of long bones. We look for the cortex and the marrow being in continuity with the underlying host bone. We note that in uncomplicated osteochondromas, the cartilage cap is less than 1 to 1.5 centimeters in adults. Osteochondromas can be described as sessile or broad-based, as we see here. They also may be described as pedunculated, in which case these osteoexcrescences will point away from the nearest joint. You can also have a condition in which there are multiple of these, multiple hereditary osteochondromas or exostoses, as they're sometimes referred to as. We look for bilateral metaphyseal widening and deformity, most commonly at the knees, like we see here, as well as the shoulders and the hips. Complications are more common with multiple hereditary exostoses or osteochondromas. And this, of course, begs the question, what complications must we all look for in any case of an osteochondroma that we see? One that's important to keep in mind in every case is neurovascular impingement. Here, the osseous excrescence is impinging on the adjacent neurovascular bundle. Sometimes this neurovascular impingement can be central, not just peripheral. Fractures can occur in the pedunculated osteochondromas as well. Bursitis may occur. Here's an osteochondroma rising off the undersurface of the scapula and rubbing against the adjacent thorax, resulting in an adventitial bursitis. So adventitial bursitis is another well-recognized complication. But the dreaded complication is malignant transformation into a chondrosarcoma. In these cases, it's usually not just whether you're dealing with 1.5 or 1.6 centimeters of soft tissue over the apex of one of these lesions, but rather there's a large heterogeneously contrast-enhancing mass over the apex of an osteochondroma when there's dedifferentiation into a chondrosarcoma. That brings up chondrosarcomas, which are the third most common primary malignant bone tumor. How do we differentiate chondrosarcomas from enchondromas? That's a common clinical question. Well, first of all, with chondrosarcomas, they almost invariably have pain when they present. Second of all, the lesion size when they present tends to be relatively large. Greater than 4 cm in the axial skeleton and flat bones are considered a substantial predictor. We also should be looking for aggressive features, namely cortical destruction. If there's greater than 2/3 of the cortical thickness that is eroded or destroyed, or there's frank cortical breakthrough in an adjacent soft tissue mass, those are all findings that should point us in the direction of chondrosarcoma rather than an innocent enchondroma. Bone scan, it turns out, may be helpful. People at AFIP have suggested that the lesion activity in chondrosarcomas is hyperintense compared to the anterior iliac spine region in the same patient used as an internal control, and that is not the case with enchondromas. Next, we'll talk briefly about fibrous lesions. Fibrous dysplasia, often considered a developmental rather than a truly neoplastic lesion, most commonly is diagnosed under the age of 30 and may be seen as either a sclerotic or a lucent lesion. And these lesions should not be associated with periostitis unless there has been a fracture. Now, with fibrous dysplasia, there are a number of buzzwords that are used that might help you remember what these look like. Ground glass, we talked about that hazy opacity in a lytic lesion, like we see here with fibrous dysplasia. With fibrous dysplasia, there is weakening of the bone, and that can result in the so-called shepherd's crook deformity. That's the varus deformity, like we see here in the proximal femur. Another set of buzzwords that I find helpful is when you see a long lesion in a long bone. That is something that is also characteristic of fibrous dysplasia. Of course, fibrous dysplasia may affect one bone or multiple bones. McCune-Albright is the syndrome in which we see polyostotic fibrous dysplasia associated with café au lait spot, like we see here, and precocious puberty. Here, polyostotic fibrous dysplasia on bone scan, you can see the intense activity as well as the bony deformities. Next, let's talk about the most common bone tumor, I'll put in quotes, bone lesion like we see here, typically diagnosed under the age of 30. Non-ossifying fibromas have been defined rather arbitrarily as measuring greater than 2 cm, fibrous cortical defect as measuring less than 2 cm, whatever you want to call it, they're identical histologically. We typically see these in the metaphyses as an eccentric lesion with sclerotic margins, no cortical breakthrough or adjacent soft tissue mass, and these are considered don't touch lesions. Another example of a non-ossifying fibroma, an eccentric bubbly lesion in a young patient involving the metadiaphyseal region. There are some malignant lesions that are uncommon and look the same on imaging. Both fibrosarcoma and malignant fibrous histiocytoma present as aggressive areas of osteolysis with a wide zone of transition. You will typically see an adjacent soft tissue mass and sometimes areas of focal bone sclerosis that looks like a sequestrum. Vascular tumors, benign and malignant. We'll start with hemangioma since they are so common. Benign proliferation of vascular channels that are displayed as coarse trabeculations on radiographic and CT studies. On CT, in transaxial cross-section, we'll see these coarse trabeculations. On MR, the dominant finding is that of fat overgrown between those areas of prominent trabeculation, high signal intensity on T1 images. Glomus tumors, considerably less common, these affect the neuromyoarterial glomus. They're sharply marginated areas of eccentric erosion, typically at the dorsal aspect of the distal phalanx. They're sort of hard to image sometimes on MR because they're often very small. Here, an example of one of these small glomus tumors at surgery. Aneurysmal bone cysts. They're often considered reactive vascular processes that may be associated with a history of trauma or certain other tumors, namely giant cell tumor, chondroblastoma, and osteoblastoma. They aren't called aneurysmal for nothing. They are expansile, and they have typically a rim of intact cortex and periosteum while maintaining a well-defined appearance. Here's one of the cases that we saw of an aneurysmal bone cyst with a pathologic fracture and intralesional fluid levels. Fluid levels are pretty common with ABCs here, fluid levels in 2 more cases, although I hasten to add that fluid levels are not specific finding for any one tumor. There is a differential diagnosis that includes not only telangiectatic osteosarcoma that we talked about, but ABC and the 3 tumors that we said are associated with ABCs listed here. With malignant angiosarcoma, thankfully it's uncommon. It looks much like other sarcomas. It looks like an aggressive lytic lesion with a soft tissue mass. However, you should look for the presence of a phlebolith, like we see here, that can help point us to the diagnosis of a vascular lesion, in this case, an angiosarcoma. Of course, we need to talk about myeloma. It's the most common primary skeletal malignancy. Malignant plasma cells simply replace normal marrow, causing these lytic lesions like we see here. Multiple myeloma most commonly is seen after the age of 40, classically affecting areas rich in red marrow, so not the distal skeleton of older adults. Of course, we see multiple small punched out lytic lesions in multiple myeloma. Two more examples shown here. Now, plasmacytoma is defined as myeloma occurring at a single site. Patients typically develop multiple myeloma within 5 years. In this case of plasmacytoma, the patient did go on to develop multiple myeloma, but it was a solitary lesion at this time, a rather nonspecific lytic expansile aggressive lesion that had broken through the cortex and caused a pathologic fracture. Next, we're almost home, almost to the end. We're talking about some benign miscellaneous lesions, namely solitary bone cyst, also referred to as a unicameral bone cyst. This is a true cyst in kids, presenting as a lytic lesion with a narrow zone of transition that is often somewhat expansile, typically affecting the metadiaphysis. It's centered centrally within the marrow space and does not have any periostitis. That is, unless there's a fracture, in which case we need to look for the pathognomonic fallen fragment sign. Here, the initial fracture is shown with its pathognomonic fallen fragment. We see subsequent radiographs at 1 and 2 years, and then by 6 years, you can see that the predominant finding is not osteolysis, but rather that of osteosclerosis. So these lesions evolve and heal over time. That is the general natural history. 3 more examples of solitary bone cysts in different patients, just to show you that these lesions look bubbly. They're in young patients, typically metadiaphyseal, and whenever you see a lytic lesion, including an expansile one that thins the cortex, be on the lookout for a pathologic fracture. Solitary bone cysts are true cysts, so we see homogeneously hyperintense fluid-like signal on fluid-sensitive images with marginal contrast enhancement only after GAD. What about Langerhans cell histiocytosis? Of course, that's a proliferation of histiocytes, unknown cause, that clinically may simulate infection. The prognosis for any given patient depends typically on the age when they present and the disease extent or burden. The typical features are a geographic lytic lesion with a non-sclerotic margin and no matrix. Here is another example of EG or LCH. There are 2 forms of LCH. The localized form, more common. It, by definition, is localized to bone, has a favorable prognosis, and again, we look for that geographic lytic lesion with a non-sclerotic margin and no matrix. On the other hand, the multifocal form of LCH involves multiple organ systems. Here, hepatosplenomegaly was present. These patients tend to present younger and have a less favorable prognosis. Multifocal LCH. The buzzwords to remember here: beveled edge, that simply refers to the uneven osteolysis of the inner and outer tables of the skull. Vertebral plana, although not specific for LCH, does refer to the pathologic collapse of a vertebral body that is characteristic of this condition, whether that is in the lumbar spine, as we see here, the thoracic spine, or the cervical spine. Giant cell tumors of bone, so named because of the osteoclastic giant cells. These have certain specific features that I think should be committed to memory. They occur typically in skeletally mature patients with closed physes as an eccentric lytic lesion abutting the subchondral bone plate, and they have a non-sclerotic margin on radiographs, typically with a narrow zone of transition. No matrix. So here, I swear I had this exact case on boards with the same image quality. They most commonly occur adjacent to the knee. They could also occur around the wrist. That's the second most common site. Always look for pathologic fractures. And in the pelvis, they tend to present when they're a little bit bigger, not so early, so with expansion and cortical penetration in up to 1/3 of cases. So, of course, CT and MRI are helpful in workup to define the soft tissue extent and stage the lesions. Finally, some miscellaneous malignant lesions. Ewing sarcoma is the second most common primary malignant bone tumor. Histologists call this a small round blue cell tumor in the same category as LCH and osteomyelitis. Ewing sarcomas, of course, are aggressive lesions. In long bones, tends to target the diaphysis with an age peak of 10 to 15 years of age. In flat bones, we see an aggressive lesion with often ill-defined margins, no matrix, no osteoid. What about chordomas? These are typically considered low-grade malignancies that arise from notochord remnants. They're locally aggressive, often with a rather bulky soft tissue mass, and most commonly, of course, affect the sacrum, followed by the clivus and vertebral bodies. Finally, what would any discussion of Louisville be without adamantinoma, a rare lesion of variable aggressiveness, commonly considered a low-grade malignancy. And you can think about this lesion in particular when you see a bubbly eccentric lesion in the tibial midshaft eccentrically. Now, metastases in real life are 25 to 100 times more common than primary malignant bone tumors in adults. Most commonly when they present, they're polyostotic, and they most commonly target the central skeleton proximal to the elbows and the knees, and they typically spare the distal skeleton until late, although there obviously are exceptions to any rule. The lytic metastases most commonly come from primaries of the lung, followed by kidney and breast. Of course, blastic metastases commonly come from prostate, breast, and bladder, and we need to think about metastases in the differential diagnosis of an ivory vertebral body, as we'll talk about later. So with that, I think we've achieved some of our major objectives, talking about how to systematically approach diagnosis, some staging concepts, and some classification into 6 major tumor types. And now, since this is a review course, we're going to review the dozen favorite Ant Minis in a 2-minute lightning round. Again, I think my voice is failing, so if you could help me out with getting the right diagnosis in the lightning round, that would be great. So what I think I see here, particularly well on the CT that I recommended, is a small nidus with a central calcification in a young patient. This is consistent with everyone. Osteoid osteoma. I think this really helps solidify it in your brain. So if you want to use your verbal skills, it's good practice for when you have to use your verbal skills in a few months potentially. Okay, so here we go. I see a very aggressive pattern of periosteal reaction in the metaphysis of a young patient. This is consistent with everyone. Osteosarcoma. And I know you know most of these. I just think it's good. It can be confusing. There are a lot of different tumors out there, so we just want to hit the highlights and the Ant Mini. So here, of course, we have a chondroid lesion. It's small. It does not break through the cortex. This chondroid matrix is characteristic of a benign chondroid lesion. Everyone, enchondroma. Very good. Okay, here we have an osseous excrescence. It's pedunculated, pointing away from the joint. The cortex and marrow are in continuity with the underlying host bone. It's at the metadiaphyseal region. This is consistent with everyone. Osteochondroma. Very good. Okay, here, unfortunately, we have a bulky soft tissue mass arising from this bone tumor. There's chondroid calcification. This constellation of findings is most consistent with a malignant chondroid lesion. Everyone, chondrosarcoma. Very good. Okay, now here we have a young patient with a metaphyseal lesion, eccentric. There is a pathologic fracture. This is the most common bone lesion that we see in young patients, and this is consistent with everyone, non-ossifying fibroma. Okay, here I would say we have an expansile. Now, I'm going to go out on a limb. I'm going to say it's aneurysmal. It's aneurysmal, and there are fluid levels and a pathologic fracture, and this is consistent with everyone, aneurysmal bone cyst. All right. Okay, here are 3 patients with the same diagnosis, metadiaphyseal lesion, young patient, pathognomonic fallen fragment signs. This is indicative of everyone, solitary bone cyst. Okay, well here, those 4 diagnostic criteria that we should look for when we see this appearance are satisfied. We have an eccentric lesion in an adult that's subarticular, well-defined, non-sclerotic margin on X-ray. This is everyone, giant cell tumor. Well, here a flat bone with an aggressive pattern of bone destruction in a young patient. This is particularly worrisome for everyone. Ewing's sarcoma. Finally, if you don't remember anything else, it's all downhill after 40. Multiple lytic lesions, and even though these are distal to the elbow and the knee, we will need to consider myeloma and metastases.